Welcome, everybody. Welcome to the Department of Internal Medicine Grand Rounds. Today is September 15th, 2022. Thanks for joining us both online and here in person. Thank you. So just to remind everybody, this is the Grand Rounds. It's every Thursday at 12 o'clock. Folks that want to add the calendar invites to your Outlook calendar or online, there is either in person, there's a sheet at the top, or in a few minutes, I'll put the link in the chat so folks can add that. For those that are virtual online, if you want to attend one of the in-person conferences, we are gathered here at the George Ben Johnston Auditorium, which is behind Sanger or outside the Medical Education Building. The directions are in the announcements that go out weekly. We are continuing with this virtual approach for the remainder of the year, and we appreciate any feedback. I will put a link in the chat shortly for folks that want to provide some feedback. So without further ado, I will go ahead and start our introductions. Today, the title of the talk today is Back to Basics, Restructuring Quality and Safety. This is one of our 4 special lectures. We have 4 MMI quality and safety lectures throughout the year. And so this is the first for this year. Our speakers today are Dr. Georgia McIntosh. Dr. Carolyn Marcelo has pre-recorded a message. And Dr. Eric Shafer is here from internal medicine. So let me introduce our speakers, and then we will go ahead and get started. Dr. Georgia McIntosh is an associate professor in the Division of Hospital Medicine. She received her medical degree at Penn State University and completed her residency and chief year here in internal medicine at VCU. She's an avid educator and has completed her graduate certificate in medical education and previously served as a core educator in the internal medicine residency program and director of the hospitalist pathway. She has been awarded Outstanding Ward Attending by the House staff and most recently earned the 2020 Leonard Toe Humanism in Medicine Award presented by the Arnold P. Gold Foundation. She serves as the Associate Chair of Quality and Safety for the Department of Internal Medicine and was recently appointed to the Associate Chief Officer for Quality and Safety at the health system level. She maintains a strong interest in academic hospital medicine, quality improvement, patient safety, and medical education. Welcome, Dr. McIntosh. Dr. Carol Marcelo has pre-recorded a message today. She is out for maternity leave, but she is presenting today virtually. Dr. Carol Marcelo is an assistant professor in the Division of Hospital Medicine. She received her medical degree at West Virginia University and completed her internal medicine residency training here at VCU. She is interested in medical education and was the Department Grand Rounds Director from 2019 to 2021. She currently works as an academic hospitalist and has been recognized as an excellent educator teaching in the PCM class as well as on the wards. She has a particular focus on quality and safety and currently serves as the Quality and Safety Director for Internal Medicine House Staff Services. Dr. Eric Shafer, he is the Quality and Safety Internal Medicine Chief Resident for this year, 2022-2023. He attended medical school at Virginia Tech Carilion School of Medicine and completed his internal medicine residency here in 2022 before staying on as a chief resident. He's passionate about performance improvement. In October 2020, he won first place at the Virginia ACP Resident Abstract Competition with his QI project titled Clinical Pathway for Timely Antibiotic Administration for Inpatient Neutropenic Fever. After his chief year, he hopes to stay in the area and continue working on process improvement projects. Welcome, Dr. Shafer. I will go ahead and transition. Dr. McIntosh, are you starting? Okay. Let us load the rounds. For folks online, your attendance code, we will put that back up on the screen towards the end of the lecture. All right.
Thank you. All right. Well, thank you, Dr. Bergman, for that great introduction. And thank you all for joining us. I'm Georgia McIntosh, for those that don't know me. And so this Morbidity, Mortality, and Improvement Conference is a little bit different from what we normally do. So thank you for indulging us a little bit in this work. But I think that this is a good way as we start our academic year to kind of understand what our real mission is with this work, and really help to drive future projects. So I have no conflicts of interest to disclose. So the learning objectives for today, we're going to talk a bit about the main components of our restructured quality and safety vision for the hospital system. We'll talk a little bit about the elements of the Diabetes Management Project Action Plan, and that is going to be, as Dr. Bergman said, by Dr. Marcelo, who graciously recorded her information before going on maternity leave. And then Dr. Eric Shafer is going to be talking about the goals of our current resident handoff project. So this is how I feel most days. I don't know about you, but this has been a challenging time. And not just with COVID, and honestly, COVID has been on the back burner, at least in my mind. But as we are challenged with our current healthcare system, with our transition to our new EHR, I very frequently feel that the house is on fire and that we are just trying to put out fires. And so that is kind of guiding a little bit about where I think that we should go and kind of focus our efforts. So that being said, I'm going to start a little bit with the big trends for our health system. And this specifically is not for just the Department of Medicine, but what we've seen in terms of serious safety events and sentinel events over the whole health system. In red, you see calendar year 2020, and then in blue, it's 2021. And so one of our biggest opportunities for improvement is with coordination of care, specifically with regards to teamwork and communication. I don't think that that's a surprise to anybody that if we are not communicating effectively, that we will see more safety events or sentinel events that kind of get illuminated. And so we definitely have seen that, but significantly worsened over the past year. Medication errors, so not just with reconciliation, but maybe with wrong doses or wrong medications, are also a challenge that we've seen. And this was something that we saw before our transition to Epic, and continues to be a challenge now. Our third piece is with delay in diagnosis or delay in treatment. So this might signify a diagnostic error, so maybe a wrong diagnosis or a delay in diagnosis. But part of this might actually signify a delay in recognizing or relaying or reacting to a patient that is decompensating. So that delay in escalation is one of our challenges that we've seen borne out in serious safety events. And then to round out our current state, falls have significantly worsened over the past year. And then procedural challenges. So not getting patients what they need in that really critical time of getting procedures. So all of these are places that we continue to see trends and that we're focusing our efforts on. So this helps me to kind of frame how do we approach all of these challenges. And I think going back to the concepts of the high reliability organization really helps me to focus on how do we do this work and do this work well. And so the 5 characteristics of high reliability organizations, I just want to spend a few minutes talking about and helping us to really understand and focus on what can help us in the future. So much of this was taken from the Agency for Healthcare Research and Quality. So one of those key institutions that helps to drive a lot of quality and safety initiatives. So the first is preoccupation with failure. And if on first blush, that might sound like a negative, just to think about failure and focus on failure, but actually it gives us an opportunity to understand the defects in our system and really proactively think about what could go wrong. So this is actually a positive thing, because if we focus on those things that could go wrong and hopefully put interventions to prevent that, then we can actually prevent harm to actually reach our patient. So focusing on our near misses is actually a good thing. And our goal is to increase our near misses and hopefully decrease the errors that actually reach our patients. Our second piece is reluctance to simplify. So the key piece of this is that people in high reliability organizations understand that this is a complex, dynamic work that we do, and that we don't really need to simplify things and put a one-size-fits-all solution to every problem, but really understand that there is a significant amount of variation that is appropriate, and to understand when that is appropriate versus when variation is an error. So understanding kind of those nuances and really reduce reluctance to simplify is potentially a good thing. Third piece is sensitivity to operations. So this is that big picture understanding, or that situational awareness. I like to think about this from that the page or the email that we get when there is a significant event that's happened in the community, maybe a significant traffic accident or a hazmat accident, something like that. So everybody kind of has that same awareness of what everybody is challenged with. And so we are able to make those small changes, that small adoption, so that we can serve our patients in whatever situation that we're in, and help each other in those situations. Fourth is deference to expertise. So really understanding who are the experts, who are the folks that know that work well, and really using them as much as possible. And with that, allowing any staff member that has any concern, that has ideas, to really have that platform to be able to speak up and voice their concerns or ideas about things that might help our patients. So not just using the person that has previous expertise in an area that might not be actually doing that work currently, but really understanding what is needed at that time, and asking questions and using your people in your neighborhood as much as possible. And then the fifth piece is the commitment to resilience. I like to think about this as the growth mindset. So assuming and knowing that the system is at risk for failure and accepting that, and then working towards quickly assessing where that failure might happen and putting quick things into place to prevent that failure from actually reaching our patients, and responding to those critical, challenging situations in a quick fashion. And that's an opportunity that we have to really make that quick assessment and quick change. When I think about using the HRO, those 5 principles, it also helps me to think about the system as well as individual failures. And this is more in terms of the failure mode and failure mode analysis piece, but really understanding where systems fail and how that might lead to individual failures and how that ultimately lands towards an error. So it's good to think about this kind of holistically. So the structure, was the organization not structured to provide people with what they need at that moment? Culture. So maybe the organization's culture doesn't really support people doing the right thing at the right time, or maybe they get chastised for raising concerns. I think everybody recognizes that culture is really hard to operationalize, and it takes a long time to change a culture, but is the most important thing to ensure that everybody's on that same playing field. Process. So are there deficiencies in the design of the process, and that doesn't allow people to do the right thing at the right time? Policy and protocol. So currently we're in this very dynamic phase where we have changed our EHR and we have incorporated new components to our health system. And so our policies that were in place before don't really fit with our current situation. And so ensuring that we have active change and renovation to our policies and protocol helps us all to do the right thing in the right moment. And then I don't think I have to sell anybody on the challenges of our technology, how that has unfortunately uncovered many deficits in our system, and how that has led to many different errors. And then the individual failure mode, so how the individual experienced the error. So was there an issue with competency? Is it a knowledge or a skill deficit? So maybe they didn't have that knowledge in terms of what to do, or they had not practiced that skill in performing that specific task. Is there a consciousness issue? And I kind of view this as being not in the moment at the time. So the person knows exactly what to do and how to do it, but maybe they were distracted by other things. And so they know the correct thing to do, but yet they failed to do the right thing at that moment. Again, communication. So one of our biggest areas for improvement. So is it that folks are not receiving information appropriately? Is it that the sender has challenges, or the receiver? And is there closed loop communication to make sure that everybody hears the same information and understands what that means? Is there an issue with critical thinking? And this might be related to maybe fatigue. So a failure in their cognitive processing or in the decision-making at that critical thinking time. And then compliance, kind of one of the worst areas that you might want to think about in terms of individual failures. So this is when the person knows what the expectation is, and they thought about it at the time, but still chose to do the wrong choice. So this is more of a willful disobedience, so to speak, rather than a lack of knowledge or deficiency from a consciousness or critical thinking standpoint. But ultimately, our goal is to work on the system to help prevent those failure modes, as well as identify any individual failure modes so that the inappropriate act does not come into fruition. Ultimately, our goal is to get to that generative phase, the high reliability portion of healthcare. Right now, we're definitely not on the pathologic part of this trajectory, because we do care, we do want to do the right thing, and we do care if we get caught. But I would argue that we're actually in our reactive phase. So we know that safety is important. We do a lot of things at the time of an accident, but we're still in that reactive phase. And that's okay, because we have lots of opportunities. But the goal is to get to the calculative, the proactive, and ultimately to the generative phase. So really, this is just how we do business here. So we have a great reporting system. Just a little bit of data about what we see in terms of our VHS reports. So who reports consistently? The folks that do the majority of reporting are, when they identify their role, is our nurses, which makes sense. There are our frontline folks. They understand where the deficits lie or where there are those failure modes in the system. And so they do the majority of reporting. Our pharmacists also do a fair amount, and that also makes sense because they see where the medication challenges lie. And then much less are our practitioners, so our APPs, our providers. And I would argue that we love to see when providers actually submit those reports because it just helps to show that engagement, and it actually gets more attention to the folks in leadership to help make those changes. So this is my plea to continue reporting and report often. Just in terms of, again, data in terms of what we see. So we want to see those near misses, the errors that didn't reach the individual. We want to see that number go up. So currently, as you see, our current or high percentage is when errors actually reach the individual. But we really want to see that error that is detected by an individual but did not reach the individual. So we're trying to get to that kind of predictive phase in our system. And then in terms of all of the different types of events, just to get a sense of what we see, and this is not unique to medicine, this is throughout the health system, but this graph specifically is for the Department of Medicine from March to September 1st. So all of the things that we were talking about, medications, provisions of care, falls, diagnosis and treatment issues, or medication issues. And then if we drill that down to the top 10 events in medicine, again, it is those same things. And that is what we have started to focus on for the next academic year. Again, we're in that reactive portion with the goal of getting to the calculative part of HRO systems. So I put this here as I've been kind of thinking about where our challenges lie, and that burning sun kind of helps me to say, yes, this is not where we want to be, but we want to help identify where our issues are. These are the projects that have been lined out by Dr. Munoz-Price, our new Chief Quality and Safety Officer. And so I think that these will help us to frame our work, and that's what we're going to speak a little bit about our two projects today. So communication and escalation, continued work on refining that and optimizing that as much as possible. It is a big task. Medication safety, Dr. Chenard has been leading that work. Our work on handoffs, so transitions of care throughout the health system, and Dr. Shafer will speak a little bit about what our residency program is doing with that. Sepsis is one of those big diseases that is not just in the Department of Medicine, but crosses our health system, and that we really need improvement in terms of how do we communicate and escalate when patients are septic. And then other things that we are working on is with patients that get diagnostic procedures with anesthesia, fall prevention, and optimizing our radiology processes for procedure identification. And then I'm just going to make sure that I speak about our team, and I'm really proud of this team. So our newly developed health quality and safety team, as laid out by Dr. Munoz-Price, I'm really proud that all of these folks here in the Department of Medicine, although this is our overarching health system quality team, but really a great way to frame a lot of this work. So my work, along with Dr. Gonzalo Behrman, who's our new Associate Chief Quality and Safety Officer for Research, is going to help to really assess that data and drive those initiatives and help us with really getting that information in publications out there. Dr. Michelle Dahl, who is our Director for Infection Control and Antibiotic Stewardship. Dr. Melissa Chenard, who is our Medication Safety Chair, really looking to optimize how we do reconciliation and address those medication issues. And then Kristen Miller, who's our new Medical Director for Quality and Safety for Critical Care. So this team is, again, I'm proud of the team as we are in the Department of Medicine. So I'm going to end there and then pull up Dr. You?
Yeah.
Okay. Okay. This, all right.
Just make sure, sorry. Make sure we have the right.
Good morning. I'm Marcelo, and I'm the Quality and Safety Director for the Internal Medicine House Staff Services. I'm currently on maternity leave, which is why I cannot be there with you all in person, but I really wanted to be able to highlight this important topic of inpatient glycemic management for this first MMI Grand Rounds of the year. The objectives for my session are the following. We will be discussing a serious safety event related to inpatient glycemic management. I will then share why this topic is so important. And finally, I will describe some ongoing efforts to improve inpatient glycemic outcomes. I have no conflicts of interest to disclose. Let's first start with a case of hospital-acquired diabetic ketoacidosis that occurred on the inpatient house staff medicine service. A 50-year-old with history of Crohn's disease and insulin-dependent diabetes presented with abdominal pain, diarrhea, acute kidney injury, and SIRS concerning for Crohn's flare. They were started on broad-spectrum IV antibiotics and made NPO. I just wanted to share a few details about their diabetes diagnosis. Last A1C was 6.8% 4 months prior to this presentation. Patient was taking NPH 35 to 40 units 3 times a day and Lispro 15 to 25 units 3 times a day with meals at home. Their initial blood sugar was 98, so correctional Lispro TID with meals for blood glucose greater than 200 was ordered, but no other insulin regimen was added. The next morning, their blood glucoses ranged between 120s to 260s. They were subsequently started on IV methylprednisolone for their Crohn's flare, with first dose given early that evening. An hour later, their blood glucoses started rising. The patient was treated with correctional Lispro insulin throughout the night, but by the morning of hospital day 3, the medical team decided to schedule NPH 14 units twice daily. On hospital day 3, the blood glucoses continued to rise to the 400s. However, only NPH 14 units were still given. Recall that the patient's outpatient basal dose was significantly higher than that. They were taking anywhere between 35 to 40 units of NPH 3 times a day, and this is before they were on steroids. Correctional Lispro was subsequently held due to their NPO status, and during the evening, the blood glucose was temporized with regular insulin. The scheduled 14 units NPH was still given despite blood glucoses nearing 600 during the night shift. On hospital day 4, the routine morning basic metabolic panel revealed hyperkalemia, an elevated anion gap metabolic acidosis, and severe hyperglycemia to the 700s. At this point, the patient had diabetic ketoacidosis. Notably, an insulin drip was ordered, but it was the general hyperglycemia protocol order rather than the DKA HHS protocol. Serial point-of-care blood glucoses and BMPs failed to improve. Insulin drip was subsequently interrupted due to loss of IV access, so the MRICU was consulted later that morning. Also later that morning on hospital day 4, the team recognized that the insulin drip was ordered under the wrong protocol, so the order was changed to the DKA HHS protocol. The patient was then transferred to the MRICU, where a central line was placed so that the insulin drip could be resumed. Point of care blood glucoses and BMPs improved fairly quickly, with resolution of DKA by the evening of hospital day 4. There was no recurrence of DKA by hospital day 5, but the insulin drip was maintained under the general hyperglycemia protocol, which was appropriate, while the patient remained NPO and on IV steroids. In summary, these were the deviations in care and suboptimal conditions identified in the apparent cause analysis of this case. Although their A1C suggested good control at baseline, the patient was likely very insulin deficient. As previously stated, the patient was already on large doses of NPH before they were started on steroids. Therefore, they likely required more than just 14 units twice daily, even when they were NPO on admission, and certainly more than that once they were started on steroids. The team may not have been aware that there is a steroid-induced hyperglycemia protocol developed by endocrinology, which is available on the SharePoint Diabetes and Glycemic Management website. It's also unclear if DKA was immediately identified, as the initial type of insulin drip protocol was not appropriately ordered. The general hyperglycemia protocol dosing is different compared to the DKA HHS protocol and was insufficient in treating the DKA appropriately. This case does beg the question, when, in what situation, and in what patients do internal medicine providers need to consult endocrinology? Finally, the apparent cause analysis did identify poor IV access and lack of peripheral IV access team in the hospital as a suboptimal condition, but this was deemed out of scope for our group to address at this time. I will next briefly discuss some further background on in-hospital glycemic management, in particular issues surrounding inpatient hypoglycemia and hyperglycemia. Why should we care about in-hospital hyperglycemia? Hyperglycemia is common. In one study on general medicine wards, hyperglycemia affected nearly 1/3 of admitted patients. In another study of ICU patients, hyperglycemia was associated with 1.5 times higher risk of in-hospital death compared to patients with normal glycemia. These studies also found that hyperglycemia was independently associated with increased mortality even after adjustment for severity of illness, and that risk of inpatient mortality increased in proportion to increasing blood glucose levels. These phenomena were demonstrated in various types of ICUs, cardiac, surgical, and medical, and in general internal medicine units. These studies also noted a phenomenon called stress hyperglycemia, which is elevated blood glucoses in patients without known history of diabetes and with A1C less than 6.5 on admission. I wanted to focus on stress hyperglycemia because these studies noted that mortality was higher in patients with stress hyperglycemia compared to those with underlying diabetes, with a 2-fold increase in in-hospital death. The mean length of stay of patients with stress hyperglycemia was more likely to be greater than 7 days and was generally longer than patients with normal glycemia, as well as those with underlying diabetes. Therefore, we as clinicians need to pay special attention to patients who develop inpatient hyperglycemia without a known history of diabetes. What about in-hospital hypoglycemia? Hypoglycemia has been related to an increased risk of in-hospital death, with identified causes mainly cardiovascular etiologies and sepsis. Inpatient mortality related to hypoglycemia appears to affect diabetic patients more in a statistically significant relationship, and hypoglycemia increases risk of inpatient mortality regardless of length of stay or whether they are in the ICU, surgical ward, or medicine ward. Studies have also noted that the more hypoglycemic events a patient has, the higher the odds of inpatient mortality. Several studies have also shown that the severity of hypoglycemia is also related to inpatient mortality risk. In one study, odds of inpatient mortality increased more in patients with severe hypoglycemia compared to patients with mild to moderate hypoglycemia. In another study, the odds of inpatient mortality increased more for each incremental decrease in blood glucose level. Finally, glycemic control can impact length of hospital stay, with studies showing lengths of stay increasing with incidence of hypoglycemia. Length of stay also increases with severity of hypoglycemia, as well as with the number of hypoglycemic events within a given hospital stay. With the evidence of these studies and other data as well, CMS is also recognizing the importance of inpatient glycemic control. In the fiscal year 2022 Inpatient Prospective Payment System Final Rule, CMS finalized the adoption of 2 electronic clinical quality measures, beginning with the calendar year 2023 reporting period, fiscal year 2025 payment determination for the hospital inpatient quality reporting program. The goals of these measures are to track and improve practices of appropriate glycemic control and medication management. The severe hypoglycemia ECQM will assess the rate of severe hypoglycemia caused by administration of medications. The severe hyperglycemia ECQM will assess the number of hyperglycemic days among total qualifying hospital days. For the learners in the audience, I wanted to briefly discuss what ECQMs are and what they're used for. ECQMs are clinical quality measures specified in a standard electronic format that uses data gathered from the EMR. An example is the safe use of opioids ECQM, which assesses how many patients are prescribed or continued on 2 or more opioids or an opioid benzo concurrently after a hospital discharge. Initially, ECQMs were voluntary, but they have been required since 2016 for the Hospital Inpatient Quality Reporting Program and the Medicare Promoting Interoperability Program. The Hospital IQR program gathers quality of care information and makes it available to patients to make more informed decisions about healthcare options. This data gathering is also meant to encourage hospitals and clinicians to improve the quality of inpatient care. The Medicare Promoting Interoperability Program was established to incentivize hospitals to implement, upgrade, and demonstrate meaningful use of EHR technology. Under these 2 programs, hospitals must report on 3 other ECQMs in addition to the mandatory measure. Currently, there are 9 ECQMs to choose from, and each year CMS updates their list. So next year, the severe hypoglycemia and severe hyperglycemia ECQMs will be on this list. Now that we have established that inpatient glycemic management is essential for safe and high quality care, we need to turn our attention to how we can get to that ideal state. Inpatient glycemic management has been a long-standing struggle in our institution, and the interventions I am about to discuss are works in progress. So input from you all would be greatly appreciated as we work through this systemic problem. Our first intervention, originating from the serious safety event discussed at the beginning of this talk, was the establishment of a short-term interdisciplinary working group. Without the individuals listed on this slide, the following interventions could not have been possible. And I really want to acknowledge, in particular, our endocrinology colleagues for helping the rest of the group begin to really understand the root of the problem. An important point made by our endocrinology colleagues is that many resources for inpatient glycemic management already exist in our environment. For example, the Diabetes and Glycemic Management SharePoint site is a comprehensive resource for clinicians and can answer just about any question you may have about blood glucose management. It's fairly easily accessible via the intranet, seen in this picture here. But to encourage more usage, we asked Epic informaticists to add a direct link to the SharePoint site in all of the insulin order sets in Epic, as shown in this picture here. Speaking of Epic, insulin order sets were built up to make glycemic management as streamlined as possible. So please use the order sets every time you order insulin. Avoid using one-time insulin orders. There are obviously order sets for basal bolus sub-Q insulin regimens, like the one I just showed you. but there are also order sets for steroid-induced hyperglycemia, as well as insulin for enteral feeding and TPN. Finally, you can have the glycemic management guides at your fingertips on your smartphone using the MicroGuide app. The instructions I've shown here in this picture for downloading the guide can be found on the SharePoint website. While there is already a lot in EPIC geared toward glycemic management, we wanted to see how we can further optimize its resources and orders through the use of best practice alerts and standing nursing orders. These alerts are still in progress and will likely take several months to finalize and roll out. Currently, we are piloting the development of one BPA at a time, starting with the first one in blue here. We are cognizant of the risk of alarm fatigue and want to ensure the usefulness of this first BPA before rolling out the others. The proposed standing nursing orders are also still under preliminary consideration at this time, shown here. Finally, we recognize that our ability to fully understand the problem of glycemic management at VCU is extremely limited. Reviewing serious safety events retrospectively is not ideal in combating this issue. As we know, data is scarce right now, but we are working with enterprise analytics staff to develop EPIC dashboard reports for blood glucose management. Currently, we have one report in production, this one here, but we are working toward additional reports. Lastly, the previously discussed interventions will not be as effective without appropriate education of stakeholders. Our endocrinology nurse practitioner colleagues have done an outstanding job developing an educational in-service for nursing staff, and several units have already received this education. I have been working with a phenomenal group of residents, shout out to Juhi, Alan, and Andrew, who are currently developing a QI project within the residency program. They're looking at knowledge and attitudes of glycemic management among residents and are going to follow that up by an alternative method of resident education. Finally, I'm grateful for the opportunity to use today's MMI session to provide further awareness to my medicine colleagues about this problem. I know I'm just touching the tip of the iceberg, but every little bit helps. Finally, if anyone has any additional ideas for educational avenues, do please reach out to me after my maternity leave, obviously. In conclusion, I know that this is not just a Department of Internal Medicine problem. There have been multiple safety events across all service lines. The problems surrounding glycemic management will not be fully addressed if they are discussed only in the silo of internal medicine. I'm so grateful for the overwhelming support from the topmost leaders of the institution to move this issue to the forefront. There have been extremely recent efforts to put together a more permanent interdisciplinary working group led by medication safety and include representatives from endocrinology, internal medicine, surgery, pharmacy, and nursing to more deeply analyze this multidisciplinary problem and to come up with sustainable strategies. I am so excited to be part of this group, and I cannot wait to find out what we can accomplish when I return in December. With that final thought, I just wanted to thank you all for your time and attention. Again, I regret that I'm not there with you all and that I will be away for some time, but I'm very excited for the future and what I can do to help the institution improve glycemic management when I return. Thank you.
Wonderful. Thank you, Dr. McIntosh. Thank you, Dr. Marcelo. I will turn it over now to Dr. Shafer. Just give us 1 second. Just transitioning here. Sorry. Great. Dr. Shafer.
Hey, so again, I'm Eric Shafer. I'm the Chief Resident for Patient Safety and Quality Improvement for the Internal Medicine Program. I also want to give credit to Taylor Pence, our Associate Program Director for Quality Improvement, as well as our great PGY3s in Internal Medicine who have contributed to this project. I'm here to talk to you about our third-year capstone project to improve the Epic handoff tool. So first, to highlight our efforts in teaching quality, safety, and performance improvement in the internal medicine residency department. So it starts with our interns PGY 1 year, where during orientation, they receive lectures introducing them to some of these topics, as well as a simulated wards day, preparing them for their first day of an inpatient rotation. Our interns also send the chief residents their discharge summaries when they're starting out so that we can provide them feedback on those before they're able to independently sign them on their own. We also have a patient safety conference series, which occurs during the interns' core conferences on Tuesdays. Then as we go to the second year for our residents, they have a house staff mortality review that they do as part of some of their rotations. When they're at the VA, we also do emergency response training, which helps them practice responding to rapid response as well as code blue events. They also have their procedures rotation where they practice central lines, lumbar punctures, and LPs with a standard process for evaluating patients and doing the procedures. Then third year, they each have a 2-week dedicated QI leadership rotation during which they contribute to their class's QI capstone project. So the QI capstone project is voted on by the PGY3 class at the beginning of the year. They had the options between working on the Epic handoff tool, standardizing substance use management inpatient, standardizing discharge instructions for patient, continuing last year's project, which was about the verbal handoff process, and then standardizing management for inpatient agitation and delirium, and have chosen to go with this Epic handoff tool project that I'll talk to you about today. So giving some background on the handoff tools used on the inpatient setting. So here you see an example of the RAMS handoff tool, as we called it, that we had in Cerner. So this includes a combination of both free texted information and then also auto-populated fields, including vital signs, labs, intake and output, and then some medications. Now with Epic, we have different handoff tools that we use. So the top is the one that is used for internal medicine. It includes only free texted fields. And then at the bottom is the handoff tool for vascular surgery. This includes several auto-populated fields like for the RAMS tool. However, the trade-off with this is the vascular surgery handoff only prints 1 patient per page. And the internal medicine version and the RAMS handoff tool that we had with Cerner would print multiple. This can be a problem for our wonderful night colleagues when sometimes they're covering more than 50 patients, and a handoff tool of more than 50 pages works great for swatting bugs, but is not overly effective as a handoff tool. And then you can see this reflected on the left where we polled the medicine teams to see which medicine teams were using which version of the handoff tool. We see most of them using internal medicine, but then there are some that appreciate having some of those auto-populated fields when this is used as a rounding tool as well. So some of the teams are using vascular surgery and cardiac surgery, which include more of those auto-populated information. Having no standardized choice for the handoff tool also creates room for errors when teams are trying to transition from one to another for the night colleagues, or since this is completely at the discretion of the residents, if they make a choice to switch from one to the other. So our goal overall is to get one that our residents can overall be satisfied with using as a rounding tool, and then also works well as a handoff tool for our night colleagues. Some background research done about handoff tools. The IPASS format, which is our suggested mode of handoffs, has led to reduction in handoff-related errors. And then you see on the right a summary for those that aren't familiar with the IPASS mnemonic. It starts with illness severity, then patient summary, action list, situational awareness, and then synthesis by the receiver. Some research also showed that the handoff tools that included free texted as well as auto-populated data helped to improve the overall completeness of handoffs. Handoffs were found to create a significant cognitive load on providers, and the structure of the handoff tool has been found to be effective in reducing that burden. The CORS rounding tool, which is similar to our RAMS rounding tool in Cerner, also allowed internal medicine residents to round faster, make decisions more quickly, and improved communication overall with the care team. So looking at some of our baseline data on handoffs, this was created by observing our residents hand off to the night team and then seeing if they included all the different elements of our IPASS. On the top left, starting with illness severity, we see that about 25% of the time, residents were missing illness severity with some of the patients when handing it off. And this is broken down into always in the light blue, usually in the yellow, sometimes in the gray, rarely in the orange, and then never in the darker blue. So as I said, 25% of the residents were not giving this illness severity with all their patients. It was similar with patient summary, with about 25% of residents not giving a patient summary for all of their patients. Action list was similar, and then situational awareness, that drops down to about 59% of the time being given. And then synthesis by the receiver, less than half of the time, half of the residents give it on all of their patients. As I mentioned, these tools are being used both for rounding and handoffs. So we want to look at some measures for how this is functioning as our rounding tool as well. So a great application, Signal, is able to automatically pull data from Epic, and we were able to pull the minutes of chart review per patient per day for our residents and able to stratify that by their PGY year. And then this is broken up by week from the start of the year. So our plan, once we're able to make our changes to the handoff tool, is to look at this and see how our changes have been able to affect the amount of time chart reviewing patients prior to rounds. In addition to using the Signal data, we're also sending out surveys to our residents to collect data on the efficiency of their pre-rounding, where we'll ask them how long they spend on average pre-rounding on their patients in the morning, as well as the percentage of time that they finish pre-rounding early enough to discuss the plan before rounds begin. As a part of that same survey, we also want their input on the elements that they think are important as far as a handoff tool and a rounding tool. So we're, as you see, have a lot of options for things that could be included, and going to ask them what they think would be most valuable. And we separate it into handoff tool and rounding tool to preferentially choose things that are useful for a handoff tool, since that's where we see a lot more of our errors, as opposed to rounding tool is a lot of times more based on efficiency, and then also to help minimize the number of pages that are included on our handoff tools. As I said, the big thing we need to consider when deciding which of these elements to include is how we can balance the information auto-populated with the number of patients per sheet. But we have a lot of other things to discuss as a group. Orientation, we can choose to make the handoff tool portrait or landscape. And then, as I said, there are still some area for improvement in terms of incorporating all the elements of IPASS into our handoff. So we're going to be thinking about how the organization of the handoff tool itself can encourage our residents to use IPASS on every handoff. So more to come once we get some input from the residents and able to make some changes. And there are my citations. And I think we can open up to any questions.
Yeah. We'll start here with the in audience here. While I get things focused. Thank you, Dr. Shafer. We appreciate that. Thank you, Dr. McIntosh and Dr. Marcelo. Any comments from the audience here? We have a mic that we can pass around if people have specific questions. If you're online, please feel free to use the chat. I will get to you all in a second. Start here. Oh.
I can very enjoy the fellows with babies. Anyway, I'm impressed by the fact that it seems like the outpatient setting is ahead of the inpatient setting in terms of continuous monitoring of things, whether it's blood pressure or pulse ox or blood sugar. We do that all the time now on a continuous basis, and I'm wondering if anybody's doing that in the hospital, monitoring like they do EKGs or, telemetry, to have more information quicker for our patients that are in this.
So,
I mean, since we have technology for continuous use, continuous monitoring.
I can speak a little bit about the project that Dr. Kelly was doing with the continuous blood sugar monitoring for patients with COVID. That was part of the, that was one of the projects. We have not been able to develop something with our inpatient services. And I know that there were a number of different challenges with the continuous blood sugar monitoring with the COVID patients, but I can't speak towards the details. So I think it's something that we should be going towards. Yeah.
My question pertains to the reporting of errors. And because most errors or concerns are self-reported. And I think everyone is aware of that case in Tennessee at Vanderbilt with that nurse. Have you seen a difference in the rate of self-reporting before and after that case? And does the hospital have a policy on reporting and errors and the support people get? And obviously that's not the news.
Yeah, I think that's a really good question. When that case was came out in the media, there was a lot of, I can speak towards a lot of talk within our department on concerns people had in terms of reporting themselves. We have not seen a difference in terms of what has been reported. And there was very targeted and quick, deliberate communication by our interim chief nursing officer that said, we support our frontline staff. We really want to ensure that folks feel supported in the environment, and that if you see something, definitely report it, but more of a just culture framework rather than a punitive framework. So we have not seen that has affected our reporting here.
Good job, but McIntosh, I want to first say thank you for all the great and hard work you put into those monthly reports from the quality department. They're very helpful to see what you guys are doing. Helps to give us a sense of direction where we should be on the lookout for other improvements and our personal practice. One thing I was curious about though, that graph you had about calendar year, I think it was what, 20 versus 2022. It's quite alarming. Or 21. In terms of the increase in the series of NSM rates, any idea from your department standpoint what the signals are in terms of where those are occurring? I know, like, anecdotally, staffing shortages are a problem. I know I still struggle a lot with like looking for Epic, so maybe HR might be an issue as well. But I was curious what you guys have uncovered.
Some of it. Basically, you hit on.
This is the one you.
Yes, some of those challenges. So part of it was staff burnout, honestly, with COVID, and then transition to Epic. We do encourage folks to report, and so part of this might be more attention towards reporting, and so maybe some was in the system that we just didn't know about, and with more encouragement of reporting, that we're seeing those numbers go up. But we think that it was a little bit of everything. Burnout, new staff, new grads that might not necessarily know what is the expectation, and then as we transition to Epic, a lot of challenges too.
We have two questions online. I will transition to Dr. Gill. You should be able to share now your question.
Oh, can I, yeah, my chat was disabled. Can I just talk?
You go ahead. We can hear you.
Yeah, hi, great job. Georgia, congratulations. And thank you to Carol. I wish her good luck with her pregnancy, and thank you, Eric. I had the pleasure of interacting and teaching all three of them, Georgia a while ago, and Carol in the middle, and most recently Eric. So great job, kudos. I just wanted to point a couple of pitfalls and provide a couple, a few pearls. One common mistake that's made is, when patients are hospitalized, they're put on, for lack of a better word, sliding scale, which we abhor as endocrinologists. And, the correct terminology is, the correction scale, but that should be done in conjunction with the use of basal and basal and bolus insulin. So oftentimes, basal insulin is held when patients are NPO. Of course, it goes without saying that prandial would be held. There's no need to hold basal insulin. Everybody needs basal insulin, whether they're eating or not. Secondly, I work at the VA, and one common mistake that's made in the emergency room on the way to either ICU or hospital floor, when patients are hypoglycemic, they're given IV insulin bolus. Unless IV insulin bolus is followed by a drip, you're wasting insulin and causing either euglycemia or hypoglycemia, and that's going to last only 8 to 10 minutes. And patients are going to become hypoglycemic again within no time. IV insulin gets out of the system within 8 to 9 minutes. I would much rather give sub-Q insulin if you were to choose between IV bolus, not followed by drip. Those were a couple of observations, and I thought I would try to spread that word. Thank you.
Thank you, Dr. Gill. It's great to hear your voice, and thank you for that support.
Sure.
I will say that I have not seen IV insulin errors being reported in our system, so I'm hopeful that that is something that we are not challenged with at our campus, but I think that that is something that is education that needs to spread. We are working towards improving education especially for a lot of our newer grads kind of throughout, as folks are coming into the healthcare system, that we do not need to stop basal insulin. I agree that continuing that for NPO and helping them to understand what the half-life is of that basal insulin, I think is part of that education. So thank you for those comments.
Great, thank you.
Thank you. There was one other online. Dr. Carter was just asking you a question about pilot programs in the ambulatory care setting to improve patient safety. Any last minute comments on that?
Yeah, thank you, Dr. Carter. So that was definitely one of our areas that we want to increase focus, because a lot of this is inpatient. And so one of the pieces that Dr. Munoz-Price has put into place is to outfit the ambulatory space with a dedicated quality and safety manager. So Jewel Claiborne, who used to be our person overall, is now tasked with ambulatory space, and Nicole Plato is the internal or inpatient quality and safety manager. So there will be more attention and initiatives for the ambulatory space as well as the inpatient space.
Wonderful. We are at the top of the hour, so just want to say thank you once again, Dr. McIntosh, Dr. Shafer, and Dr. Marcelo online. So thank you all so much for your time. We appreciate it. We'll stick around in person for a few minutes. For everybody online, thanks for joining today. Tune in next week. That concludes our grand rounds. Thanks.